Good morning. I'm Gordon Smith, the state's Director of Opioid Response in Governor Mills' office. I want to welcome you all to our monthly webinar, which leads up to the governor's Annual Opioid Response Summit on July 20th this year in Portland. Hope many of you will have an opportunity to join us at that summit, and the registration materials will be sent out early next week on that. The topic today, which has been a very popular topic, we have over 400 individuals registered to join us today. And the topic is the intersection of substance use disorder and child protection. And we are so fortunate to have as our faculty today, Mark Moran, who's the chair of the Maine Child Death and Serious Injury Review Panel. Mark works up at Northern Light and has been involved in this area, and is really very fortunate to not only have him this morning talking about the annual report and the work that the Child Death and Serious Injury Review Board does, but also just to have him in that role. We also are joined by Bobbi Johnson, the Associate Director of Child Welfare Services at the Office of Child and Family Services, which is part of our Department of Human Services here in Augusta, and Dr. Todd Landry, the Director of OCFS. The presentation is going to be done by Bobbi, and Dr. Landry is available as a resource and answering questions and that type of thing. I'm also joined by our SUD program manager at the Office of Behavioral Health, Madison Barassa. Thank you, Madison, for joining us. And I always want to thank Lorena Liberty at AdCare, who helped put these programs together and does the logistics for us. If you'd be good enough when you have a question to put it in the question and answer box. Some of those we'll answer as we go along. And then if there is, hoping that there will be a brief opportunity as we get close to 12:30 to answer, for me to pose some of those questions to our panelists. I also want to mention the Maine Association of Recovery Residences has its first film festival of films featuring the topic of recovery from substance use disorder, and that's in Portland at the Abramson Center at the University of Southern Maine, June 23rd, 24th, 25th. All those proceeds benefit their scholarship for beds for people that need a recovery residence and can't personally afford them. So we're very excited about that. Opening night is on that Friday night from 4 o'clock to 9 o'clock, and we'll be featuring that night the films that we've made as part of our own efforts here in Maine. So with that, Mark Moran, I'm going to turn the program over to you, and you can take it from here. And thanks so much to all of you for joining us.
Thank you, Gordon. Let me share my screen here. This one. Gordon, can you just give me a head nod if you can see that?
It looks good, Mark. Thank you.
Perfect. Thank you. All right. Good afternoon. Well, still good morning. Still good morning, everyone. Appreciate you all joining us today. My name is Mark Moran. As Gordon said, I'm the chair of the Child Death and Serious Injury Review Panel. I'm also the social services manager at Northern Light Eastern Maine Medical Center, where I've been for the last 17 years. And my prior employment was as a child protective services worker for OCFS here in Bangor. For those of you who aren't familiar with the panel, I'll give you just a very brief overview. We are established in state statute, Title 22, Chapter 1071, Section 4004, for those of you who are interested in such detail. The panel's charge is to review cases and make recommendations to state and local agencies to help essentially improve the child welfare system. Our charge is to review both deaths and serious injuries. Thankfully, we don't have the number of deaths on a large scale like some other states do. And so we think it's also important to review cases where there's a sort of a near miss, a near fatality or something that could have been a fatality. Our specific panel membership, some of it is included in our authorizing statute. We have always interpreted that as a minimum. We have expanded our membership beyond what the minimum statute requires, sort of as needed, as we've encountered different disciplines or different service sectors over the years. We've added folks to our group. And then we invite others on an ad hoc basis when we have a need for a subject matter expert that isn't part of our group normally. The panel meets monthly. Generally speaking, we don't meet during the summer, but we met 9 times in 2022. And I'll just say briefly that I use this slide deck for presentations on the entire report. I'm only going to highlight the issues that are relevant to substance use related disorders today, but you'll see other content on the screen that you can pay attention to or not. We have 3 levels of review that we conduct. Level 1 reviews are what we call summary reviews. Each month we get a report from OCFS for all of the reports they receive in a given month that are either child death reports, serious injury reports, and then once a year we look at a group of a year's worth of ingestion related reports, specifically ingestions. Those are just usually a paragraph in length. We kind of scan the content of them. We look for themes, we look for noteworthy issues in a given case, and we pull from those and put them on a sort of a list of cases that we want to review in more detail in the future. Our level 2 reviews are cases or months where we would review 2 of those cases at a time, 2 or 3, centered around a common theme. So if, for example, we were looking at the topic of fentanyl ingestions, we might pick 2 or 3 cases where that has been an issue and look at all of those in concert to get a bit broader view than just a single case would provide. Our level 3 reviews are our most in-depth. We did 5 of those case reviews in 2022. We have typically a presentation from OCFS staff on a specific case. Usually law enforcement will be involved in that sort of presentation as well. And the panel will then have a more in-depth discussion about the issues that particular case highlights. We get educational presentations in our group throughout the year. Of note to this talk today, we had a presentation last year from the folks at the Northern New England Poison Center, Karen Simone's group. Always very helpful to hear from them about what the trends are, what they're seeing as time goes by. We also have to provide quarterly updates to the Health and Human Services Committee in the legislature. And so we did the first 2 of those last year, and there's been 2 thus far this year. We also participate in a New England regional meeting of other states' versions of our panel. Some states only focus on fatalities, but we join in with them, typically meeting somewhere central in New England each summer. So you'll see the areas that I've highlighted here obviously will be the ones that are relevant to today's talk. One of the more noteworthy findings in our report this past year was related to the number of ingestions that we saw, which increased 114% year over year. There had been a 4-year downward trend, and now we are in our 2nd year of an upward trend. We'll get more into the specifics of that in a moment. Serious injury reports also increasing, and child death reports are relatively stable. With regard to ingestion specifically, nearly half of the reports that we reviewed from 2022 were related to marijuana ingestion. And this is all manner of ingestion, maybe not all, but many. pieces of marijuana plants themselves, paraphernalia that's would have marijuana residue on it, butter, batter, ice cream, soda, chocolates, other edibles, brownies, a whole variety of different ways that folks would use marijuana, whether legally or not legally, depending on the age of the person. Medicinal marijuana versus adult use, sort of recreational, as folks say. So that's certainly a growing issue, and it's an issue that we anticipated based on the experience of other states. Other places that have made adult use of cannabis legal have seen increased emergency room visits, have seen increased ingestions, a whole variety of related problems. And then of additional note in our ingestion data is 7 cases just in the 1 year of fentanyl ingestions, children ingesting fentanyl, I believe always illicit in our sample. And so that, of course, is a growing problem as well. Earlier this year, the Government Oversight Committee had a presentation from the staff in the Office of Program Evaluation and Government Accountability, OPEGA, on the death of a 3-year-old little girl from Old Town, whose name was Haley Goading. And Haley died as a function of a fentanyl ingestion while in her mother's care. Normally, I wouldn't be able to talk about specifics of any given cases, but because that was publicly reported by someone other than my group, I can make reference to it. One of the observations we made in our reviews last year was related to naloxone. I know Gordon is a particularly strong advocate for increasing the availability of naloxone around the state, as is the governor. And our observation was essentially that the focus of use and availability can't any longer be just on the adults who are overdosing or at risk of overdosing, but more specifically, we also have to focus on the kids in those environments. If 3-year-old Haley had a dose of Narcan available to her, anytime in the 24 hours that she was impaired from an overdose prior to her death, maybe she would still be with us today. Additionally, we highlighted the notion of individual cases at times being viewed as accidental or intentional, looking at cases through that lens, instead of looking more broadly at the potentially neglectful environment in which those circumstances happen. It's a similar dynamic that we have seen in selected cases we've reviewed of gun violence, children who sustain gunshot wounds. They tend to be a question at the end of the day of, was this an accident or was this an intentional thing, rather than looking at the potentially negligent actions of the parent related to what happened. We also were able to discover that there's no comprehensive data collection and monitoring of total ingestions. The Northern New England Poison Center has some data. The Maine CDC has some data. OCFS has some data. I'm sure the folks in the Maine care world have data. Hospitals have some data, but there's no one single repository for all of that to allow us to have a good sense of how broad a problem this really is. In terms of other systemic observations from a multidisciplinary perspective, not just the Child Protective Services element, we highlighted the notion of medical care and primary care in particular. And within the primary care setting, the importance of well child care and well child visits. We can't overstate the importance of children getting to well child visits. The anticipatory guidance that's provided by primary care providers in that setting is really key in many ways to primary and secondary prevention efforts, sometimes tertiary efforts when problems are identified. But children who don't show up at well child visits should require some additional attention, and I'll talk more about that in the recommendations section. The first of our recommendations relates specifically to the ability of healthcare entities to test for fentanyl and other synthetic opioids in their testing assays. We have seen many examples around the state of healthcare facilities, laboratories that don't include fentanyl as part of their standard urine drug screening protocol, for example. And from what we've been able to determine, it seems in many cases that the physicians or other healthcare providers who are ordering these tests aren't aware that fentanyl isn't included. I'm aware of a very recent case where a child presented at a more rural hospital, had a urine drug screen, and was negative for all substances on the panel. Came to a larger center and had a more comprehensive urine drug screen that then showed the presence of fentanyl in the urine. That's important for multiple reasons. One, we certainly want to be able to treat kids and adults, of course, effectively when they come in with something like that in their system. But it also has implications for OCFS staff in terms of the safety planning that they may or may not need to do in a given case, or the reunification of a family that they may or may not need to do in a given case. It may be that they view a parent as doing quite well, being, maintaining their recovery, maintaining their sobriety, but in fact, they might be unknowingly putting a kid back in a home where the parent is still under the influence of illicit opioids. We also decided that we would task Gordon, Maine's Director of Opioid Response, this year to evaluate options for increasing naloxone presence in homes where kids and opioids coexist, and then make whatever appropriate recommendations from that evaluation he deems fit. And to his credit, Gordon's been very, very receptive, has been a great partner in this work. And I know some of the efforts in this regard are already underway. Number three, we tasked ourselves, the executive committee of the panel, with communicating and collaborating with Maine's Opioid Clinical Advisory Committee, co-chaired by Dr. O'Connor, Elaine O'Connor, and Lisa, Lisa's last name escapes me. I apologize.
Letourneau, Lisa Letourneau.
Letourneau, thank you, Gordon. I knew it was an L and I couldn't get it off my tongue. We have already had a meeting with them. My co-chair, Dr. Amanda Brownell from the Spurwink Center for Safe and Healthy Families, attended a meeting with them a couple of weeks ago to talk about how best on a larger scale to address recommendation number one specifically. How do we get hospitals and healthcare facilities and labs to change their protocols to add fentanyl or other illicit or other synthetic opioids to that testing panel, and educate providers so that they're aware when they order these tests, if it doesn't include fentanyl, they can add it on as a special additional test, but they have to be aware that it's not included to begin with. Last one on this slide of note is that we recommended the development of some sort of data tracking or monitoring mechanism that can get a good sense of ingestions overall, to inform a more complete understanding. With that understanding, perhaps then additional systemic level recommendations can be offered. Related to the topic I mentioned earlier, we think OCFS should review incidents in context, not just assessing intent versus accident in a single episode. They have been, and I understand are continuing to provide lock boxes or lock bags of some sort, both as secondary and tertiary prevention measures with the families that they encounter. We support that effort and are hopeful that it will continue. On the issue of well child visits, we think pediatric primary care providers, whether it be a pediatrician or a family medicine doctor or a nurse practitioner, PA, whatever you happen to have in your community, that they should develop protocols in their offices, in their practices, for reviewing cases in which there are repeated missed well child visits. And we understand that parents miss well child visits for a variety of reasons. We're not suggesting that one miss should require a review or a report to OCFS or anything like that. But if there are resources within the practice, within the medical practice, that can be employed to reach out to families and say, hey, we saw you didn't make this 4-month well child visit for your baby. Is there anything we can help do to reschedule that or make sure you get here for your 6-month well child visit? Sometimes transportation is an issue. Sometimes there are other resources involved, childcare for other siblings, perhaps, that sort of thing. Poverty could certainly play a role in that. But other more troubling trends can be fueling that behavior as well, like intimate partner violence, like substance use disorder, like mental health needs not being met. And so if there's an opportunity to reach out to those families, we want to make sure that can happen and happen fairly proactively. If those resources aren't available or identify issues that are worthy of reporting to OCFS, then we would encourage, of course, reporting to OCFS in that circumstance. And then related to that, we recommended that OCFS view repeated missed well visits as sufficient cause to investigate a child's safety more thoroughly when there are additional risk factors present, such as parental history of substance use disorder or concerns about intimate partner violence, those sorts of dynamics. That's all I have for you today. I'm happy to hold for questions at the end in the interest of Bobbi getting to her content as well, but happy to also take Gordon's lead on that.
No, I think we can go right ahead. We've had a couple of questions, some we've handled in the chat, but I think we should have Bobbi do a presentation, and we probably will have some time for questions.
Great.
Thank you, Mark and Gordon. So I'm going to talk about OCFS and in particular child welfare services and our efforts to support families impacted by substance use disorder. Some of this will connect back to the information that Mark just shared, and others will be information about our efforts. I know that this is difficult to see. This is our OCFS Child Welfare Services practice model. It is available on our website, and it outlines the principles and the values by which we work with families and work with our community partners and other stakeholders, extended family, our tribal partners, and others. So I just wanted to start with this because this really sets the stage for how we want to engage with families that find themselves in need of child welfare intervention. So in 2020, the OCFS data showed that 52% of all removals in Maine had parental substance use as a risk factor. In 2021, the rate was 53% and has been consistent over the past several years. And this chart shows the rate of substance use as a risk factor at the time of removal. And so Maine continues to be above the national average, which is the blue line, and the orange line shows the national average. So when I say substance abuse is a risk factor, it means that it's one of the reasons or one of the factors that we identified when we were working with the family. It doesn't mean that that was the reason or the only reason that children were removed. The other thing that we learned in our data was that on average, it takes individuals working toward reunification 3 months longer when substance use is a risk factor. And so now I'm going to talk about some of the ways that we have integrated responses to substance use disorder into our system. And I'm just going to start with our child welfare training. And so within our foundation's training curriculum for new caseworkers, which is a collaborative effort between the University of Southern Maine, Catherine Cutler Institute, and the Office of Child and Family Services, we have information that's embedded into that process for new caseworkers. We also have provided training, an overview of substance use disorder and engaging with individuals with substance use disorder with for all of our staff by Dr. Judy Josiah Martin. We have been working on a drug recognition training in partnership with the Maine Drug Enforcement Agency. And this is a training that they've provided to some of our district offices over the past 10 or so years, maybe even 15 years. And so we are bringing that to a statewide availability for all of our district offices. And then the last training that I just wanted to highlight was one related to ingestions data and a Q&A with the Northern New England Poison Control Center. And so we are working with Karen Simone, who has been a resource for the Child Death and Serious Injury Review Panel, to bring information about ingestions to our staff. We are also in the process of co-locating substance use disorder specialists in each of our district offices, and their role will be to provide case consultation, training, and coaching support, participate in family team meetings, and help guide case planning for individuals with substance use disorder. And this has been, again, we've had this at different times over the years in some of our district offices, and it's been a necessary resource in order for staff to have that access in the moment when we're working with families and trying to develop either safety plans or our longer term rehabilitation and reunification plans with families, to have an expert related to in substance use disorder that can help guide some of that planning for the staff, but also in our work directly with the families. We're also working in partnership with the Office of Behavioral Health Services to build a cadre of recovery coaches that can provide peer supports to families involved with child welfare services. So they would support families in navigating their child welfare involvement. The plan at this point is to pilot it in the 3 parts of the state where we have family recovery courts. So that's Bangor, Augusta, and Lewiston. And to also have the availability for these individuals to take community-based referrals in those geographic areas. So they'll have the individuals that are part of the family recovery courts, but then also be able to work with other individuals in those areas. We are in the process of reviewing our child welfare training and screening tools, and we're doing that in partnership with Dr. Letourneau and Elaine O'Connor, Dr. O'Connor, and the clinical opioid group of providers. And so we've looked at our structured decision-making tools. We've also looked at the UNCOPE brief screening tool. So within child welfare, for any family, whether substance use disorder is identified as a potential risk factor or not, we do what's called the UNCOPE brief screening tool. And it really is intended to identify individuals that could benefit from a referral for either a levels of care assessment or a more intense service. And so we use that tool across the board in all of our investigations. We've also been seeking expert consultation. And so we've gotten national scans from a couple of organizations. So the Casey Family Programs, the Capacity Building Center, which is connected to the Administration for Children and Families. We've done peer-to-peer calls with other New England states, in addition to asking other New England states that we haven't done peer-to-peer calls with for information about how they train, support their staff and families related to substance use disorder. I also participate in a national child welfare leaders work group, and the focus of that work group since I joined a few months ago has been largely related to fentanyl. And so that's been beneficial. We're also working on safe storage. And so we have procured safe storage lock boxes and bags for distribution from our district offices. And we are in the process of procuring additional resources. We're also thinking about what would be helpful to put in those lock boxes and bags. So, you know, would Narcan be helpful to have? Would some sort of information or, you know, for example, about the Northern New England Poison Center. So we're looking at how we can be part of the solution and help support families. We're developing a plan to provide training and distribute Narcan on a voluntary basis to child welfare staff. And Gordon's been our partner in that work. The other thing that I just wanted to mention too was one of the things that we learned with one of our peer-to-peer calls. They also use the Uncope Brief Screening tool, and they were doing some work to build it out, which I really appreciated, and to begin to train their staff to have conversations with families about, if you're using, how are you ensuring that your home is a safe environment for children? And so just providing some education about cleaning practices, about the increased risk that fentanyl presents to children in particular who are either crawling, always putting their hands in their mouth, and might be exposed to those type of substances. And so those are some of the things we're learning and thinking about how to integrate into our practice. And then we have family recovery courts in Bangor, Augusta, and Lewiston, which I had mentioned previously. And those continue to be similar to the other recovery courts, but it's focused on individuals that have an open child protective case and substance use disorder as a factor. And it provides a higher level of accountability and a judge that meets with them regularly, treatment providers and case managers that help them in their recovery process. So collaboration with other state agencies and for prevention, treatment, and recovery. And so the state has invested $1.9 million to expand treatment in rural areas. We are increasing the main care rate for residential treatment, or we have increased, I should say, by an average of 37.5% since November of 2021. We also are a national leader around Medicaid or main care. We have been awarded what's called the 1115 waiver, and that has allowed us to expand services for main care enrolled parents with substance use disorder as a risk factor, to continue to allow them to have main care while they are in the reunification process with child welfare if their children are removed. We have partnered with the Office of Behavioral Health and the Maine CDC around the Maine Mom program and improving care for pregnant and postpartum Mainers with substance use disorder and their infants. We also I've had the opportunity on a couple different occasions to spend time with the Maine Moms group and partner with them to educate our communities about their experiences and ways to improve the system for them. And then improving access to adolescent treatment supports is another component of the work that we are doing in partnership with our other state agencies. And this slide is my last slide, and it just really reflects how important collaboration within OCFS with families and across state and community partners is to ensuring safety, permanency, and well-being of children. And I would add also prevention. is a critical component of that piece. And I think Dr. Landry was going to talk for a second about some of the work that we've been doing within the department related to prevention.
Yeah, thank you, Bobbi. I appreciate that. And before you stop screen, well, I might have you screen share again in a moment. But I do want to just point out one thing that was announced just a few weeks ago. Some of you may have heard or read about it. The department did partner with the Maine Child Welfare Action Network and a large number of other community participants and individuals to develop a comprehensive child safety and family well-being plan that quite specifically focuses on primary prevention and the role of communities in providing helping communities to provide supports for families and others in their neighborhoods and in their parts of the state. That is available on the website in multiple places, both on the DHHS website as well as on the OCFS website. If you have not seen that, we can certainly provide the link to that report. I know many of you on this call probably participated in some of those community sessions. We had several hundred individuals participate in those sessions that helped to inform what we're calling version 1.0 of that plan. And we appreciate that tremendously. And we're calling it version 1.0 because we believe this is the first step on a multi-year strategy to increase prevention efforts. It's important to note that it's not just prevention related to substance use disorder, although that's certainly an important component, but we're talking about the broader picture of prevention and the fundamental belief that we have that one of the best ways that we can keep kids safe is by helping families be as strong as possible that they can be. So I wanted to mention that in particular. The other thing that I wanted to quickly say, I made a comment in the Q&A that we would answer a question live. There was a question about reunification. Bobbi mentioned on one of the slides that approximately 50%, 53%, I believe, in the last reporting year of cases where there was a removal or a court order for a child to come into state custody. 53% of those cases involve substance use as a factor, as a contributing factor. Wanted to make sure everyone was aware that does not necessarily mean that in almost all cases, it is not the only contributing factor. In many cases, in most cases, there are multiple contributing factors that ultimately lead to a decision to file and for the court to order, if appropriate, a child to come into state custody. However, when it comes to those kids who do come into state custody, where substance use was a risk factor, I think it's really important and interesting to note that we've looked at those children who come in with that as a risk factor, and the reunification rate for those children is almost exactly the same as those children without substance use as a risk factor or contributing factor to their removal. However, it is also important to note that on average and in aggregate, it takes about 3 months longer for reunification to occur in cases where substance use is a contributing factor versus those cases where it is not. For those of you who work in this field, that probably makes some logical sense because sometimes substance use as a contributing factor may take a bit longer to address versus some other contributing factors from time to time. So I did want to point that out as a question or as some additional information to the question about reunification. And I thought it was some interesting data for you to hear and to be able to share. The last thing that I'll mention real quick is at the beginning of Mark Moran's slide, we're very proud of our partnership with the Child Death Serious Injury Review Panel. OCFS, as you heard, contributes and participates in all of those meetings as an active participant, and we appreciate their feedback and perspectives. He showed at the beginning of his slide that the Child Death Serious Injury Review Panel does an annual report. That annual report is available on the Citizen Review Panel website, and there you will also find the department response to the recommendations in the CDSIRP annual report. Again, some of the recommendations, most of the recommendations go beyond the aspect of substance use disorder. However, I wanted to make sure you knew that if you want to go and dig a little bit deeper and learn a little bit more about the CDS IRP recommendations in their annual report, you'll also be able to find the department response to those recommendations as well. And with that, Bobbi, I'm going to stop and turn this back over to Gordon. I think we have some time for some Q&A. I know several of these have been already answered in the Q&A chat, but I'll go ahead and turn it back over to you, Gordon, and we can perhaps facilitate some additional questions and answers.
Thank you, Bobbi, Mark, and Todd for your presentations. I have saved one question for whomever would like to answer it from our friend Kathleen in Falmouth, as I recall, because it's complicated. So this is more than we could type out in a moment. But I think a very fair and sincere question. So if parent or if one or more parent is actively using, why are children still in the home? So that light touch, I'll send to either Todd or Bobbi, whoever would like to. I think you should maybe both have an opportunity to comment on that, because it's complicated.
Yeah, it is complicated. And Bobbi, I think you might be helpful if you discontinue or stop sharing the screen now, so that participants can see us a little bit more for this part. It is a complicated factor, and certainly is something that our staff never make these decisions about potential filing of a PPO, preliminary protection order with the courts, where a child could come into our custody. Sometimes there are ways that the child can remain in the home, but with an appropriate safety plan, the child can remain safely with that family and with their parents. Other times that may not be possible. And so it depends on a broad array of aspects related to that question. It's not a simple one. Every single case that we consider at OCFS is individual, and we have to look at them as individual cases. Every family has their own individual risk factors as well as protective factors. And that is something that has to be considered in the overall question of imminent risk of serious harm to the child. And that is a legal standard. You might hear the term and we all might have our own personal definition of what's sometimes called IROSH, which stands for that imminent risk of serious harm. That is the legal standard that has to be met, and that's defined in our statute. And that is what we have to demonstrate to the courts before a preliminary protection order could be filed, and the court then considers that, or a judge considers that, to whether to grant that or not. And so it does get, it can be sometimes a little bit complicated. But hopefully that explains a little bit of the background of kind of the level that we have to meet at OCFS, legal standard level that we have to meet in order to file for a protection order and for a judge ultimately to agree or disagree. And I think it's just important to note that ultimately that decision does lie with the judge. It's our responsibility to file that petition where we believe that IROSH standard has been met, but ultimately it's a court's decision as to whether or not to grant that. Bobbi, perhaps you can fill in a little bit more from a more specific practice standard and how some of these things are considered as part of the structured decision-making tool and the work that happens with our intake staff, investigation staff, and our supervisors on each individual case.
Yeah, so we do have the structured decision-making tools that we use throughout the whole case process, beginning and intake when we're screening reports to determine if they're appropriate for child welfare intervention. And so there's questions that our intake staff are asking of reporters, and then they're using that information to screen it through the tool and determine if there's suspected abuse or neglect that rises to that level. During investigation, we are doing the UNCOPE tool, which I had mentioned, and there's really two components to that. One is information that we're gathering from the individual themselves, and then information that we're gathering from other collateral contacts. So it might be their partner, it might be another family member, it might be providers. and making decisions about the level of danger or risk that is posed to a child. And danger and risk are really two different concepts. One is like immediate threats to their child's safety, and the other is, if this child remains in the home and these risk factors are present, they could have adverse outcomes. The thing that we have to be able to demonstrate is impact to the child. And so that's really what the immediate risk of serious harm is referring back to, is this child an immediate risk of serious harm, and what's the impact? And there are individuals in our state that use substances that are doing it in a way that is not creating a condition of danger for their child. And so those are some of the things that we are assessing as we complete our investigation process and make decisions about whether a child is unsafe and then the level of intervention that someone may need. So there are people in our state that make safe plans for their children when they're using, maybe in recovery, may have had a relapse. Like there's a lot of, as Director Landry said, there's a lot of different factors that are considered when we're making the decision about a child remaining in the home with their parent.
Mark, do you want to comment on that question?
I think Dr. Landry and Bobbi did a great job summarizing. I would just say more generally that I'm not sure we want a child welfare system that has a ton of absolutes in it because of the degree of diversity in from one family to another. The individual circumstances can be all over the map, frankly, and so to impose a protective action on a family that may not need it that's not a desirable outcome. The same way leaving a child in an unsafe circumstance is not a desirable outcome. So we don't want to make errors on either side of that continuum.
Very well said, Mark. I've got a couple questions from the chat. The question is, I think having an understanding of how prenatal reports are handled might be of interest to the prevention and treatment people. We have some prenatal reports that maybe you mentioned. So how are those handled, so to speak?
And Bobbi, do you want to tackle that one? Because that gets into some statutory definitions of when OCFS can be engaged and involved, but also into the plans of safe care that some of you may have already heard about, or we can provide a little bit of information on.
Yes, so the department is only able to be involved with families when there is a child that has been born. That's the definition of when we are able to be connected. That said, though, we do take prenatal reports of potential abuse and neglect, suspected abuse or neglect for children that when born could be in circumstances that are dangerous for them. We don't open those. We do keep them as part of our Katahdin system. And so we have access to those reports. If a child was born and then a subsequent report was called in after that child's birth, we have those reports to be able to refer back to. We do, on prenatal reports, have the ability to refer them to Cradle Me. So Maine families and public health nursing for some earlier intervention than what the department is able to provide. And through that process, we hope that they can begin the process of working with that mom and her partner to create a plan of safe care for when that baby is born. So that we can have that individual connected to services, supports. Some may be related specifically to substance use disorder. Some may not be. We also receive a lot of reports, or we do receive notifications when children are born of individuals who are prescribed, Suboxone or methadone and have an infant that is born. And those are required to be reported to the department, but we don't open those reports unless there is also suspected child abuse and neglect after that child is born.
There is a question that I'll make a comment on and then see if any of you would like to answer it. What is the OCFS position on parents or caregivers who provide cannabis to minor children? As a lawyer, I just want to remind people that we still have a medical marijuana law that permits, under certain circumstances, minors to have access to marijuana with their parents' involvement. So I would imagine that that is part of what informs the OCFS position on that question. But Todd or Bobbi?
Do you want to tackle that one or do you want me to?
We either one. If you want to start off from the perspective of from an intake call, and then I'll jump in.
Yeah, so I mean, I think, you know, with marijuana, cannabis, what Gordon has shared is really an important consideration. I think we also, as with any child protective intake report, we're considering a lot of different components. So we're considering factors that make a child more vulnerable, such as the age of a child, you know, any information that's available about why that child was given those substances, what the impact was to the child, and then based on that and other factors, we make a determination about whether it's appropriate or not. I mean, in general, a child being given, you know, marijuana, cannabis that isn't prescribed is not something that the department would support.
I want to go back to a question that was in the chain. I think I answered it, and people I think could publicly see the answer, but it's an excellent question given the subject this morning. It was whether or not naloxone, whether there's a different protocol for administering naloxone to children. And I'm not a clinical person, I'm just a country lawyer out here. But I had occasion this week to actually review some questions and answers that are going to go on the options website. And I'm going to give you 3 websites here in a minute. But our options, knowyouroptions.me is about to have a question and
I believe we may have lost Gordon for a moment.
I can jump in briefly. I wanted to go back
Go
to
ahead.
the
Thank you, Mark.
question about prenatal reports.
Okay, I think I'm back for a minute.
You're back. Go ahead.
So let me talk quickly then. That I was told that there's no risk to children if you administer naloxone with intranasally as we usually do. That it's safe and it can be used. We certainly use it on adolescents. So that's the information that I have from the experts. Let's see if we have.
Gordon, before you go on, Mark, did you have anything else you wanted to add on that? While I know you were about to jump in while Gordon had a tech disruption.
Yeah, just briefly on the prenatal reporting question. I think when people hear the child welfare system, that term, they automatically assume that means OCFS, Child Protective Services exclusively. I tend to take a broader definition of that, and the panel takes a broader definition of that. And so if you're in a position to be making a prenatal report about a woman who is using substances during her pregnancy, prescribed or otherwise, you are also then in a position to help connect that person with the community services that are going to help her get into recovery, stay in recovery, make changes, make improvements in her family circumstances, all of those sorts of things. So the same way OCFS can refer a family to Cradle Me, you can work with the patient yourself to refer to Cradle Me. You should be aware of what your local community has to offer in terms of home visiting services and who's providing those. You may very well be able to help a family mitigate or reduce the need for Child Protective Services intervention by the time that baby arrives on my doorstep at the hospital. We've had cases like that before, where families make the changes they need to make before a child even arrives, and they take away the need to have to worry about whether OCFS is going to knock on their door.
Bobby, if you look at that question, I think it's the most recent one on Cradle Me. While I answer a previous question, I'd appreciate it. This is an easy one for me. Does the state offer any virtual or remote Narcan trainings? Yes, all of our syringe programs, as well as all of our public health departments, as well as our naloxone distribution network, they all offer training for free and remotely or in person. So that training can be 10 minutes or it can be 2 hours if you want to learn a lot about identifying an overdose, rescue breathing, and those types of things. So absolutely, on our websites, you could you'd see some of those resources. I said I'd mention 3 websites. KnowYourOptions.me has a drop-down menu by county as to what our resources are in that county. The MaineDrugData.org is run by the university. We just posted the April monthly report for overdoses. Fatal overdoses are down a little bit this year. We're very pleased to see it, but again, that could be wiped out by a bad month, so we're not issuing any press releases about it. But nonetheless, there have been fewer fatal overdoses for the same period this year than last year by about 5%. And then there's the Maine, very relevant to this conversation, getmainenaloxone.org, also operated by the university. You punch in your town, your county, it will tell you your nearest place to get free naloxone. Bobby, to you for that question that was in the chat.
Yeah, so a parent can decline the Cradle Me service, and it is one of the issue that was raised was about feedback going back to the provider about the fact that the parent has declined that resource. It's something that, as we've done the plan of safe care work, we've been working with public health nursing and Maine families on is, what information can be shared or not be shared back due to confidentiality. So the department, once we refer that to Cradle Me, we don't get that information back either about whether the parent has accepted that service. That becomes really a process between the provider and the individual who has been referred.
Probably the last question we'll take the Kristen Murray James, who does a great job as an attorney running our program for judges and lawyers who are in recovery, is asking whether referrals can be made to Cradle Me during pregnancy.
That's the best time to make referrals, quite frankly, Gordon. It's the opportune and best opportunity we're going to have to engage that family. There's not as much pressure. There's not as much crisis going on at that point. If we wait until the mom has delivered the child and we're in this little 48-hour window where we need to make a safe plan for this baby, getting those kinds of services engaged in a way that is going to significantly impact the risk of removal of a child, we've missed the boat. So as much prenatal referral as can happen, I say, let's do it.
And I would just echo what Mark said, as far as I have personally been involved in some of those cases where child welfare has received a report, and it's been a very different outcome because the individuals were able to get connected to services and supports earlier on in their process. And so it's just been amazing to see that work when those referrals are made prenatally.
Okay, just a couple things. Madison is putting in the chat the addresses for the 3 websites that I mentioned. Thank you, Madison. I remind you that these recordings and all the presentations are available on our website that we keep at AdCare, not in the next hour, but within just a few days. And you can, they're all archived, so you can look at any of these programs multiple times till you get it down solidly. I really want to thank our 3 presenters. I'm so appreciative of them joining us today. I remind you that actually at the summit on July 20th, there'll be a breakout session led by OCFS on the Child Safety and Family Wellbeing Plan 1.0. So I would encourage you to register for the summit. And I think really the theme of the summit is the power of prevention and focus on families. So there's a lot of attention, as you know, from this hour being focused on families and protecting children. So again, I thank you to Mark and Todd and Bobbi and for being such great partners in this work. Thank you, Madison and Lorena. And I hope you all have a great weekend. And we'll hope to see you all in Portland on July 20th.